We will have a presentation that is on video, and it is Professor Anthony Woolf. He couldn't attend. He is on another meeting in Sweden, south of Sweden. So he sends his best regards and good luck for us and to perform this conference. And we are very happy that he actually did this and will share his experience. He's the past president of the Global Alliance for Musculoskeletal Health, and he's a rheumatologist. He has an honorary professorships and from the UK. He is involved in various initiatives, and he tries to raise awareness and impact of musculoskeletal conditions and the research that we are dealing with. So it's very nice to introduce you and to introduce this presentation, which is where he tries to guide us through implementation and future initiatives in research. We can have a discussion afterwards, but we cannot send the questions to him. So let's start the video, and then we can have comments here.
Thank you for inviting me to speak to you, and I'm sorry not to be able to be there in person, but I'm going to talk about the need for further research and the implementation of current evidence. And this is important because low back pain and neck pain are the greatest cause of disability, and they've been so for the last 25 years. So what is the need for research? What are the unknowns, and what are the priorities for establishing that evidence? And we need to look at the whole research and innovation pathway, going from invention, which is the creation of new things, new ideas, new techniques and new approaches, through to their evaluation, adoption, and then diffusion into routine clinical practice so that people truly benefit from the advancement of knowledge. We then need to consider at which point is there needed most new knowledge. Is it around the mechanisms and determinants of low back pain and disability? Is it around pain itself and factors which influence acute or persistent pain? Or is it around factors which influence the impact of that pain in terms of disability and reduced function, activities and participation? So I think it's very important that we establish what is the aim, what's the outcome we're trying to focus on. And this is where research done by people within this group has identified 3 core patient-relevant outcome domains for clinical trials in non-specific low back pain. That is physical functioning, pain intensity, and health-related quality of life. And when we consider physical functioning, we have to think of participation, particularly in work, because work is good for health and wealth. And low back pain and other musculoskeletal conditions have a very major impact on work. And in some countries, this is leading to a lot of priority in trying to more effectively prevent and manage these conditions. We then need to look at the tactics to improve that outcome, which is targeting usually the processes and the determinants. In trying to establish research priorities, the James Lind Alliance in the UK has been set up and is funded by the National Institute of Health Research, and it brings together patients, carers and clinicians to priority set around certain topics and come up with the 10 most important uncertainties or unanswered questions about the effects of treatment. And this aims to ensure that health research funders are aware of the issues which are most important to patients and clinicians. This has not been applied to low back pain, but it has been to early hip and knee osteoarthritis. And for example, you can see that priorities set were around surgery non-surgical approaches, and other important priorities. So one way of trying to look at whether we know enough about a condition and providing appropriate care is doing a health needs assessment. And I've been involved in the Bone and Joint Monitor project for the last 20 years, looking at musculoskeletal health, and starting off with identifying the impact of disease, and this led to the Global Burden of Disease study, and as you've seen, the results of that showed that low back pain and neck pain were the greatest cause of disability worldwide. The next step is to know what is achievable with state-of-the-art interventions, and the gap is what I call the unavoidable burden, which is the research agenda. This is where we do not have the knowledge to close it. But then we know that in routine clinical practice, the quality of care does not meet the state-of-the-art level, and therefore there is what I call the avoidable burden of disease, and this can be closed with resources and priority. So going through the unmet burden and possible causes, one is the lack of scientific evidence, either about basic knowledge or applied knowledge. Then there's the lack of professional awareness and knowledge, lack of resources, financial, human and physical, limiting access to care and provision of care. There can be the lack of consumer-led demand and lack of priority at the personal level, but also at the governmental level. In looking at the prevention of low back pain and associated disability, there are various levels which one can intervene. There's a population approach, which is targeting everyone in primary prevention. Then there's secondary prevention, targeting at-risk individuals or those with an early stage of the condition, or tertiary prevention, where we're trying to reduce the impact on those who already have it. And where are the greatest gaps in knowledge for back pain along this pathway? In a recent article in the European Spine Journal, I highlighted some key questions. How do we ensure people develop a healthy musculoskeletal system that functions in a way to minimize risk throughout their lives? How can we prevent injuries through better behavior and physical use of the spine taught from childhood and emphasized in any setting where risks are higher, such as in the workplace or in certain sports? Can we prevent back and neck pain, or is it more realistic to ensure rapid recovery and minimize the impact of an episode when, most importantly, we need to prevent chronicity, which is where the greatest impact occurs? How do we make people more resilient to episodes of back pain so that they keep mobile and active despite them? Because we know, like the common cold, most will settle down, but people instinctively do not necessarily behave in what is now known to be the best way. We also know that medicalizing the problem can increase the likelihood of it becoming long-term, but then there are cases who do respond well to early intervention. So how do we make sure that there is appropriate triage? And can we recognize those early who will develop chronic neck or back pain, and those who will benefit more from a medical or a psychosocial intervention? So these are questions we need to address. The other issue is considering the level of evidence we need to influence policy and practice. Ideally, we want systematic reviews of randomized controlled trials, but often that is not realistic, and also we are often dealing with complex intervention for this problem. Another approach for looking for standards of evidence is promoted by Nesta, which is an innovation foundation that's developed standards of evidence. And as you see, there's some similarity to the more classic scientific approach, but basically it is trying to decide what level of confidence is that what you are recommending is effective and good value. Moving on from creation of new knowledge and its evaluation to how do we get it adopted and spread out into routine clinical practice. And this is a big gap and only recently being addressed by the research community. We know when it comes to low back pain that there's multiple clinical guidelines providing similar recommendations, but they are just not implemented. and there's still a great deal of overuse of low-value care and underuse of high-value care, and a great deal of opportunity exists to reverse this. And as you know, low-value care is when care potentially has more harm than benefit. And we really do need to know how to address it, because it is one of the curses of the modern medical world, where we are perhaps over-enthusiastic to intervene in many areas when it's not really in the benefits of the individual or of society. But we have to work out how to get a consensus of what is low-value care, what is high-value care, and there are some initiatives such as the Choosing Wisely campaign trying to get around that. We know for back pain, and it was identified in the Lancet series, that a big issue is around over-investigation and over-invasive therapeutic interventions. But we do need to crack this avoidable burden of disease. Now, when it comes to knowing what we should do, as I just said, we have multiple guidelines. It's not a lack of guidelines which is the problem, but it's actually how do we implement them. And we undertook a review of guidelines as part of the European Musculoskeletal Health Strategies project funded by the EU. And when we asked those who had authored the guidelines about whether they were being implemented, many authors did not know, and most guidelines did not include any strategy for their implementation. Now, there is the model of improvement by the Institute of Healthcare Improvement, and this focuses on several steps. What are we trying to accomplish? How will we know that change is an improvement? And what changes can we make that will result in an improvement? Plan, do, study, act. And the first step has that model of care, that pathway that we want to implement. And Andrew Briggs, along with the Global Alliance for Musculoskeletal Health, developed this framework to evaluate the readiness for implementing musculoskeletal models of care. And we do have models of care for low back pain. In NICE, we have a guideline, and that's been adopted nationally and is rolling out. And also, for example, in Australia, there's a model of care. When it comes to implementation, in the European Strategies project, we identified several key components. And a very important one is the rationale for action, the need for change. And we know this because, in a way, we are prejudiced because we are committed to this cause, but it's the people who on the ground need to implement the guideline, the pathway, that we have to influence. And in the UK, we have NHS Right Care, which is a national programme to ensure the best possible care is delivered everywhere as efficiently as possible, which is essential for both patients to improve outcomes and for the NHS in making its funding go as far as possible. The aim is to ensure people access the right care in the right place at the right time. And a key element of this is to identify variation and highlight to people where they are compared to the norm. And for example, this is low back pain, and I've highlighted my region in Cornwall, and this shows the estimated prevalence of low back pain, the MRI scans being undertaken per 100,000, and you can see on the right-hand side where my area is, which is just a bit below average, surgery spend where we're a little bit above average, and the injection spend where we are very low. So in this way, we can highlight to people where they sit and actually get them to dig down to establish the reasons and try and improve their pathways. We then have to make sure that people know what their responsibilities are. And in the health system, there's a responsibility of all levels. At the micro level, healthcare providers and patients and public have responsibilities about what patients expect and what healthcare providers offer to ensure that it is evidence-based. Then at the meso level, the health system has to provide the appropriate services and facilities, and at the macro level, there has to be the appropriate policies to support that. There's various tools which can be used to help with implementation, educational, either professions or public, organizational, regulatory or financial. And in this world, modern world, financial tools are very important. And in the UK, we've developed a return on investment tool to allow commissioners of healthcare to identify best value interventions. And within that tool, Start Back has been shown to be cost effective and is being encouraged so people can see for their local community the benefits of implementing it. Finally, you have to evaluate whether you are achieving your goal, whether things are being changed. And in the UMass project, we created person-centered standards of care, but importantly, healthcare quality indicators to measure whether the healthcare system is delivering those standards of care. And in that way, one can know whether or not one is making an improvement. So in conclusion, researchers need to invest in research efforts to address the gaps in understanding of low back pain. They need to promote research efforts that aim to identify cost-effective and context-specific strategies for managing low back pain and mitigate the consequence of its current and future burden. We need to test and evaluate new approaches and promising solutions, in particular those needed to address the burden of low back pain in low and middle-income countries. And finally, and very importantly, we need to invest in implementation research to determine how best to put existing knowledge and new knowledge into practice. Thank you.
So, are there comments concerning this? You want to start discussions around his messages? Yes, please.
Alan Abbott, Linköping University. Probably more a question to everyone in here. I thought the tool that Anthony showed, the right care tool, that showed the regional differences in healthcare behaviour, practitioner behaviour. I mean, I don't know, in our context, in the Nordic context, or maybe Nadine knows even the English context, are there similar tools being used as indicators, looking at different interventions being delivered in different healthcare contexts? It's look like a great tool.
Nadine, would you like to comment?
I don't know a lot about the data that goes into right care, but certainly it's being used to open up very helpful conversations about regional variability. Whether the regional variability might be explained by differences in case mix, of course, there's always the criticism of things like that, but it's certainly at the moment a very helpful tool to at least start conversations about unacceptable variability region by region.
Yeah. In Australia, we're also doing a lot on variation in care. We keep proposing back pain, but we have done osteoarthritis. We've done arthroscopy of the knee where there's huge variations. And from there, we developed clinical care standards, like 10 standards. And the health services are meant to be adopting those. And we can evaluate whether there's been any change over time. So we want to do the same thing for back pain, where we also know there's large variations. We already know where to go in Australia if you want an arthroscope, that's Adelaide, and where you want to go if you want a fusion as well. So.
Thank you very much.